Okay, great. So if anyone has any questions about that, you can always email us. And, if there are any issues with any of the passwords or any of the questions, but we're really happy to bring that to everybody. So this way, all the documents and everything that we discuss are always going to be available. And so you won't have to email and ask for them anymore. We're going to have them all available, all the order sets. If there are any order sets that we don't have that you'd like us to have, please let us know, and we'll update to include any order sets that you'd like us to have. Or if you have order sets that are out of date and you'd like us to review it and see what we can help with, we're happy to do that too. And I would like to say thank you to Sumaya. Sumaya has really done an excellent job updating a lot of the order sets and doing a lot of work with it.
Yeah, so please let us know if you need any new information material. We're happy to add them on. So we're today going to talk about osteomyelitis. This is a very common infection that we all have to encounter. So we just wanted to kind of go over some new data with osteomyelitis. And if you have any questions, please stop and ask us, okay?
Yeah, the time's going to be a little bit shorter than usual. But, we wanted to go over some of the highlights, some of the questions that we get frequently that I think it's a great thing to go over and discuss, and just, highlight some of the new information as well as some of the questions that we get frequently that it's always great to go over this because it's such a common thing.
So one of the most, we get asked about what antibiotic should we give, because a lot of times, a patient is having osteomyelitis, but we don't have any cultures yet. And you want to know, what should I target? What antibiotic should I start? So this was really nice, a large study, and they looked at 2001 to 2004 versus 2013 to 2017 to see if there's any changes in the bacteria. Are we seeing more MRSA, MSSA? What should I be treating? So overall, the most common gram-positive bacteria that causes osteomyelitis is MSSA, methicillin susceptible Staph aureus. It's in this study about 33%. And then MRSA. So those two are big. And then, of course, you have your strep species and Enterococcus species when it comes to gram-positive. It hasn't really made a big change, except for that MSSA, I would say, over the 10 years apart. So it's always important what you want to know, what to treat empirically. Vancomycin should cover these gram-positive. Oh, something that could cover, like if you can't use Vancodapto. And then next, for gram-negative, it's Enterobacteriaceae species. So it's still like E. coli, Proteus, if it's gram-negative. And then, of course, you have anaerobes and other types of organisms, but they're very uncommon. So if you had to empirically start somebody on antimicrobials, vancoceftriaxone, high risk for Pseudomonas vancocefapine, those type of combination is good until you have culture. Once you have culture, then you could, of course, target that organism. How do you usually take care of that?
Yeah, that's so, if before you know what it is through the culture, it's essentially what's the most likely thing. And this is showing the most likely thing is going to be Staph aureus, whether it's MSSA or MRSA or Enterobacteriaceae. So what works as far as your antibiogram, if you have an antibiogram, and here, so vancomycin would be good to cover all the Staph aureus, MRSA and the MSSA. And then, just like you said, ceftriaxone would be good for E. coli and Enterobacteriaceae in general. So that's what I do, vancomycin plus ceftriaxone until you have the culture data. So ideally, they would take the culture, and then if you need to start them immediately, that's what I would start. And then if you have something that would direct it, but if it comes back and it's unhelpful, like if the culture isn't able to identify anything, then vancomycin plus ceftriaxone or some kind of combination that covers
gram-positive and gram-negative.
Right, MRSA plus gram-negatives,
Yeah, so it's going to be, you have to come up with a combination. And of course, other important factors too. So let's say you have a foot with really bad infection and osteomyelitis, but you could smell the anaerobes, it looks necrotic, then you should add flagell for anaerobic coverage. So there are some little nuances, but for the most part, I see osteomyelitis in like leg, like, foot and toes, sometimes other sites. And one of the biggest site I see recently is spine. So we'll dedicate some time to talk about spine by itself. So if you have any questions on this, but this is how we kind of approach it.
Yeah, I think this is really good. I think if you're going to, so if I'm going to give IV antibiotics, it's either vancomycin plus ceftriaxone or something that's comparable with that. And then we'll talk about pills a little bit later. But if you wanted to give pills, it would be, again, something that covers MRSA really well, like Bactrim or doxycycline, plus something that covers Enterobacter which somewhat depends on your local antibiogram if you have one. But if you come up with a pill regimen that covers those same categories, then pills would work as well, just as well, probably.
So this was a recent study that was published in 2022. So the first author is Brad Spielberg. He's one of my idols. He's pretty amazing. So they looked at national guidance, not international guidance as well. Large group of experts got together, use of novel strategies, developed guidelines for management of pyogenic osteomyelitis in adults, so infected osteomyelitis. So they came up with some consensus. So we want to kind of go over the important part of this guideline.
And I also like Brad Spielberg. He has a website, Shorter is Better.
Yeah.
And it's the actually title of 2 of his papers he's written in the past, shorterisbetter.com, I think. But if you look up Brad Spielberg, Shorter is Better, he has a list of all the different infections, and he has short duration versus longer duration, and then has all the evidence below that. So all the papers and everything.
And he writes a really good blog when it comes to infectious disease stuff too. So if you all ever need to explore his stuff, it's really good.
And as far as these guidelines and things, these are really good because you can see how many people are on this, trying to get them to agree on something.
And they're international experts too, not just United States. So it's a big deal.
And trying to get people to agree on something can be a challenge. So these are things that they all agree on, or close to agreeing on. Right?
So one of the big things that we get asked is that many times, what kind of imaging should we be getting? So in the first osteomyelitis without PJI with prosthetic joint infection. So they looked at sensitivity. Sensitivity refers to the ability to say this patient has infection. Specificity means they don't have the infection. So they looked at what imaging or labs can tell you definitely there is infection. So if you have osteomyelitis, there's no hardware or joints, prosthetic joints, the best way to tell if they have infection is MRI, 96% sensitivity. So it's fantastic. So MRI is great, but for some reason, the patient cannot get MRI. Of course, they say PET scan and stuff. It's very expensive. So we seldom ever use it. You could go to nuclear, tag white cells, but MRI is the best if you're worried about osteomyelitis. And then they have diabetic foot infection in the below table, DFO. And again, they looked at what is the best modality tell you, like it's infected or not. Again, sensitivity for MRI is 93 to 96%. So best modality. There are patients we get into trouble because, they have hardware, they can't get an MRI, they have pacers. In those cases, you could think about CT with contrast or white cell scans or something different. But if you're able to get an MRI, it's very helpful. And then they have another table on prosthetic joint infection. What is the best way? It's interesting. In their studies, when they all came to consensus, they really liked when your hardware white cell scans, but we don't do this as much.
No, I'm not really a huge fan of nuclear studies.
And it takes a couple of days too. So MRI is pretty decent in this case, but it's just a broad range. So I think this is good to know. If you don't have a hardware for the most time, MRI would be the best modality for imaging.
Yeah, and sometimes people will say, oh, they can't get contrast or, but MRI with or without contrast is probably better than doing a CT scan anyway. Right? So, but yeah, if you can get an MRI would be the way to go.
And then another question all of these members answered was, they asked, is oral therapy appropriate for treatment of osteomyelitis? And if so, what are the reasonable patient selection criteria for administration? So when they combined large meta analysis studies, so they had over 9 studies, over 500 patients in each group, and they looked at giving IV versus giving oral, and it ended up being that neither was, it just fell right in the middle in the forest plot, meaning you could go either way. So then they had to come up with who will be the best candidates if you had to give oral, and what type of patients can we try oral. So here is some guidance on like what are the type of patients that we could give oral antibiotics.
Yeah, and in some of these studies, you know, if there's no difference, or even sometimes when they find a difference, they'll say something like, it's important to realize which patients you should choose for this. And sometimes that's not very clear, but here they actually gave some of the things that they recommend. So the patient is clinically stable, hemodynamically, and at the end, and at the site of infection, no spinal instability. So they're clinically stable. They have adequate source control. So they're, you know, if there's an abscess, it's been drained, they're no longer bacteremic, likely to absorb oral medications from a functioning gastrointestinal tract. So if you're going to give them PO antibiotics, you want to make sure that they will absorb it and it'll work. Have an available regimen used in published osteomyelitis studies to cover likely targeted pathogens. So you want to use something essentially that's mainstream. You want to use something that has been shown to work and be efficacious. Have no psychosocial reasons that preclude the safe use of oral therapy. So sometimes, you know, people have reasons why they won't take their pills. And when we give pills, sometimes we're not sure if they're actually taking their pills, but if you're giving them IV antibiotics, you can be sure that they're taking it. You have ways to make sure that it's being delivered. It's actually being taken.
So just evaluating their psychosocial needs is important. But this gives a really nice frame of who we can do oral antimicrobials. For spinal surgery, spinal infection, specifically, also they say, you know, and also abscesses, it's cleaned, it's drained, source control, there's no instability, then we can consider oral.
So this is good. So IV versus pills, if they're able to take the pills and they meet this criteria, then pills should be a good option for them. So oral versus intravenous antibiotics for bone and joint infections. So if it crosses the line, that means that there's no difference. But you can see that sometimes they're look like they're beginning to favor one side or the other. But you know, because it crosses the line, it didn't find
but what it's doing is,
difference.
but it is overall dividing for different types of organism. So it's, you know, in this study, for some gram positive, it's okay to give oral. For some gram negatives, they're saying give IV, favors IV. So again, I think looking at the prior guidelines, making sure how the patient falls, stability, source control.
And Pseudomonas, you know, and when it does move over like this, there's always a question of if you had enough patients, because if you had more and more patients, could it keep going to the right and keep favoring IV? So yeah, in general, Pseudomonas is one that you know, you want to treat very aggressively.
And only oral option we have for Pseudomonas is ciprofloxacin or levofloxacin. So if it becomes resistant, many cases, then you're kind of stuck doing IV, unfortunately, for Pseudomonas. So I really like this table. So in this, what they talk about is what are antibiotics that have good bioavailability for osteomyelitis. So again, stable patient, good source control, just like we talked about knowing those guidance. These are some of the drugs that have good bioavailability if they meet those guidance. So ciprofloxacin and levofloxacin have good bioavailability, IV or oral. Oral is like over 95% bioavailability, right? Fluoroquinolones. So that should be one of your options. What do you think about Bactrim?
Yeah, Bactrim is very good too. It's usually the beta-lactams that don't have very good bioavailability. Although here you'll see Augmentin has good bioavailability. And also Keflex, which is not here.
it's not here. I use a lot of Caflex high dose.
I do too,
Yeah.
yes. Yeah, Caflex is very good. If you could use a beta-lactam, generally we'd rather use a beta-lactam,
Yeah.
but they don't always have very good bioavailability, but Caflex is one of the
Yeah.
exceptions. Augmentin also gets in well.
And then, Bactrim is a good option. I kind of shy away in
Yeah.
elderly patients because of electrolyte imbalance and
Yeah.
AKI. So if you have
Yep.
other options, they don't have doxycycline here either. So like if you have other options, I would stay away from Bactrim because for me, 65 and older, I get nervous using long-term Bactrim.
And that the fear there is going to be hyperkalemia. It's
Yeah.
life-threatening hyperkalemia.
And can have arrhythmias.
So if you did use Bactrim, you'd have to follow them closely with labs.
Yeah. And Clinda, it works okay. I always fear, all antibiotics cause C. diff, but clindamycin particularly. Linezolid has really good bioavailability. You just have to monitor for toxicity. So bone marrow suppression, neurotoxicity, peripheral neuropathy. You usually start SSRI if they're on psych meds. So usually those happen after 2 weeks. So just keep a good eye on if you're using linezolid, again, close monitoring.
Yeah, I try not to use linezolid for osteo specifically because of I don't want to use it over about 2 weeks.
Yeah,
exactly.
Yeah.
And then rifampin, it's not one I used very often, but
yeah, and you don't want to use rifampin by itself. It's always given together, like, for biofilm, you give it with Vanco plus rifampin. You could do that as a combined treatment, but rifampin should not be given by itself because it can induce resistance. But you could use it in combination treatment. And of course, all our pharmacists here, you all know all the drug-drug interactions with rifampin, so you have to be kind of careful.
And then duration of treatment for osteomyelitis. So here it has the condition over here, osteomyelitis without retained implant, osteomyelitis with a total resection of the infected bone. And then it also has prosthetic joint infections with which, we can discuss at a later time.
Yeah, prosthetic joint, I think it deserves its own talk because it gets complicated. But in here, they say osteomyelitis without retained implant, so no hardware. 3 to 4 weeks may be adequate with debridement, but you need to kind of follow them closely. Might need longer, maybe need up to 6 weeks is what they're recommending. Osteomyelitis with total bone resection. So this is really important. We get this question all the time. Like, let's say you have osteomyelitis of the finger, but you end up having resection all the way down here, but your infection was here. Now you have removed the source of the infection. So then you could stop antimicrobials 24 to 48 hours after the surgery. So that's why they're saying short course, get the surgery done and stop antimicrobials.
So then the question is, do they have a surrounding cellulitis or did they get bacteremic?
Yeah.
If they got bacteremic, then you're treating bacteremia. But as far as osteomyelitis, if it's been cut off, they don't have osteomyelitis
That's
anymore.
a really good point. Thanks for saying that. So if they have bacteremia, making sure we treat for that. And then if they have cellulitis still, making sure, that's really good point. So let's say you cut the bone, but the skin is still infected. How long do you treat for the skin infection after?
Oh, that's a good question. It depends. Like you were talking about anaerobes earlier and the smell. It kind of depends how bad it looks. So if it looks really bad, and these can vary very greatly. So sometimes it's a clean cut and they cut it really far back away from the infection and it all looks very good. I might stop antibiotics after a day or two, but and it also depends on the patient. If the patient is, they have an uncontrolled diabetes, they have a very poor blood supply, it was a very dirty area, I may give a little bit longer, but
that's a good point.
But in general, if it's a clean cut, you can stop antibiotics then. But sometimes they'll go in and they'll resect the bone, but leave the area around it and close it up or leave it open. But if it looks pretty bad, sometimes I'll just treat a little bit longer.
One thing I always make sure is I talk to our podiatrists, orthopedic surgeons, and we ask them, like, did you get a clean bone? Was it clean? Is there any infected bone left? And if they say they're worried there's infected bone left, even if they have surgery, then we end up treating them for 4 to 6 weeks and following them closely.
That's a good point because we were mentioning clean cuts, but sometimes they go in and they essentially file it down. So the osteo is going to be dead, dying bone that's very friable and it falls apart really easily. It's kind of mushy, but when they scrape it down to hard bleeding bone, if they scraped it like that and it's not like a clean cut, then you might end up giving a longer course of antibiotic. That's a really good point, because you're never quite sure how clean or dirty it was.
So just really good communication with the surgeons is very important. And then, so most cases, if there's infected bone, 6 weeks, but can be shorter, 4 weeks, depending on how the patient is doing. So close monitoring is very important. And if you're using IV therapy for patients for a long period of time, again, 4 to 6 weeks, if you send anybody, it's really important to get weekly labs. So CBC with differential and a BMP or CMP, because depending on the drug, you want to watch their LFTs, the kidney function, electrolytes, and CBC, because a lot of times we get an AKI, acute kidney injury, or anemia. So very, very important to monitor.
And so a couple things to watch is, how is the patient doing? If you're treating for an osteomyelitis and you're giving them a couple weeks of antibiotics, doing those weekly labs, are they feeling better? Does the wound look good? Is the ESR and CRP improved? So generally I like to get it at the start of therapy and then at the end of therapy, and you like to see it normalize. And once it comes down to a normal level, then you can say, they're probably doing really well. But if something isn't adding up, then re-imaging may or may not be helpful, but trying to get as much information about how things are going and then making a decision. If the ESR and CRP are still elevated, it might give another 2 weeks or so. Is that what you do?
So if I was going to stop the therapy at 4 weeks, but the SED rate and CRP still high, I'll extend it out and then recheck everything, re-see the patient, make sure they're doing okay before stopping therapy.
And then vertebral osteomyelitis. This is good because we've had a number of these recently.
So vertebral osteomyelitis, native vertebral osteomyelitis in adults is often a result of hematogenous seeding, basically meaning from blood to the back, the spinal area, disc area. Diagnosis when it comes to vertebral osteomyelitis, a lot of times it's delayed, because a lot of times, the patient complains of back pain. And then a lot of times you think back pain is just a muscle, or not walking correctly, or other misdiagnoses. So they get, it's kind of scary, because some data show up to 3 months in delay in diagnosis when it comes to vertebral osteomyelitis.
Yeah, and then patients will say, well, I've always had pain there, but it may be worsening pain, because a lot of times when you get osteo, if they got bacteremic, it will set up in a spot in their back that's already not healthy. They already have an unhealthy part of their spine, and it will set up there and start growing there. So if someone had a recent fever or recent infection and they say they have back pain, it's important to have a high suspicion.
And if the back pain,
it's difficult. Sometimes.
But if the back pain is persistent, it's bad, please consider imaging their back and getting labs, including ESR and CRP, a good history to make sure they didn't have recent bacteremia, especially the people that we see is they had 2 months ago staph bacteremia. Now they have all this back pain and ends up being they have staph vertebral osteomyelitis.
Any recent infections plus back pain, any fevers plus back pain. Think about this diagnosis when back pain associated with a known or current recent bacteremia, back pain associated with fever, elevated inflammatory markers like ESR, CRP, back pain in patients who are IV drug users, dialysis patients, chronic indwelling venous catheters, or unresponsive to physical therapy. So generally what happens is that we'll say they have back pain, and then the hospitalist will say, do you think we should image it? And I've gotten accustomed to saying yes, because if we see 100 patients, if I guess on every single one of them, I'm going to miss a few. And especially if they've been in the hospital, they have all these things going on, it's better just to get the imaging and have it be negative.
And by the time they get to the hospital with back pain, it's been going on for so long. So I also say, yes, get imaging just to make sure. So common organisms that are involved, again, in vertebral osteomyelitis, Staph aureus again, just like other sites, just like we talked about earlier, it's MSSA or MRSA. Usually if they had bacteremia with Staph aureus 3 months prior, most likely it's now festering and growing. MR of the spine is helpful. And then if you want diagnosis, like we usually love working with our interventional radiologist. If it's not a serious infection, a discitis, a little abscess, they'll go put in a needle, get us a culture, so we know what to treat. So that's really helpful.
Yeah, this is good. So once it's identified, so say the patient has a fever and back pain, you get imaging, they say possible osteomyelitis, discitis, then the next step, and if we get called and they'll say, should we start antibiotics right now? We'll say, well, if it's possible to have interventional radiology, put a needle in and get a piece of it for culture, it's better to hold off on the antibiotics, see if they can get that culture. And then if you wanted to start antibiotics after that's done, then it's okay to start and then follow the results of the culture.
Yeah. Only time that you will give antibiotics if they're unstable or septic,
Yes, yeah.
But if they're stable and this has been going on for months,
Yeah,
I would say get the culture before starting because it's been going on for months.
And that's something, are they hypotensive? Are they in the ICU? How are they doing? And they say, oh no, they're totally fine. They just have back pain.
Yeah.
Then it's okay to wait and get the culture. Or if they have bacteremia and they have this osteomyelitis finding on the imaging, then if they're bacteremic with something you can implicate in the osteo, so if it's Staph aureus, you'd say, oh, we don't need a culture because it's going to be Staph aureus osteomyelitis of the spine with bacteremia.
Yeah, I agree. So if you have somebody comes in with MR, say bacteremia, and they have back infection, now you could say that's what it is.
Right.
Yeah.
If they have a knee joint infection, if they have a shoulder infection, then you just say Staph aureus and then osteomyelitis, septic joint with bacteremia. Yeah,
that's a very good point.
Yeah, anytime they have a knee blow up while they're bacteremic, I consider it an infected.
Yeah, that way, like it's always important to get it washed out, but you don't need that to diagnose the organism.
Right. Yeah, exactly.
Yeah. I like this picture a lot. It kind of tells you like what are the different infection sites in our spine. So vertebral osteomyelitis, when the actual bone vertebral area is infected, like here. Discitis in between the bones. Spondylitis covering everything, bone and the disc space. Epidural abscess is right here, the epidural space. And then implanted associated with spondylitis over here internally. So kind of gives us a better picture when the radiologist says discitis, where they're talking about, versus vertebral osteomyelitis, where they're talking about.
And then we'll ask, can the interventional radiologist put a needle in there? Is it accessible? And sometimes it is, sometimes it isn't, sometimes it's too small. But if they can get a piece of it, that's great. But yeah, knowing where it is, it can be very helpful.
Dr. Horn, how do you think about when there's epidural abscess? For me, when there's epidural abscess, it worries me that I have to cover with an antibiotic that needs to get into the CNS space. Do you give a CNS bioavailable drug here?
If it's easy to do, I do. Yeah. It's something like oxacillin or nafcillin. One of the best things, I know one of our partners gives oxacillin on a 24-hour pump. Yeah. Which if you can give something on a 24-hour pump, that's the way to go.
Yeah. So what I usually do is, let's say this patient has MSSA infection. If it's vertebral here or discitis, I'm okay with cefazolin. It gets in there nice and good. But if it gets in here, then I end up using oxacillin or nafcillin. Is that kind of what you do too?
Yeah. It's if you have that, if you're able to do that, and it's just. And why I say that is because the frequency of giving it. But ideally, if you could put in a 24-hour pump that slowly pumps it in over 24 hours, that's would be a good plan.
Thank you.
And then as far as diagnosis of vertebral, we talked about this a little bit. So X-rays, not that great. MRIs are really the what should be planned for. And then except in septic patients or patients with neurologic compromise, empiric antimicrobial should be withheld if possible until you can get a sample of it for culture. And image guided or intraoperative aspiration or biopsy, if you're able to do that, that would be the best thing to do.
So empiric therapy, stable patient, patient with septic type presentation and neurological compromise. So stable patient, wait for and get cultures.
Yep.
a septic patient, give broad therapy, and then you could get culture.
Yeah, you want to make sure they live first
Yeah.
off, right?
Neurological complication, it's just not us. It's like ID and surgeon.
Yeah.
Get the neurosurgery involved immediately.
And if they do a surgery, we'd ask them to get cultures, but
Yes.
all right. And then treatment duration and monitoring. So when it comes to osteomyelitis, as we discussed before, it's going to be 4 to 6 weeks. Here with spine, I usually go 6 to 8 weeks.
Yeah, spine is much longer. Agree.
Yeah, and that's there's some studies saying that longer is better for vertebral and spine. And I do the same thing with following the ESR CRP. With spine, I always get imaging. I always do follow-up MRI for spine just because I'm so worried about spines.
Yeah. If things are not, some people might not, but I always get follow-up imaging to it, end of therapy, because I am worried about like failure. So if you're following your ESR and CRP and it's going on the wrong direction, or patient has fevers again, back pain is getting worse, have low threshold to re-image and make sure like you don't have a failure of your treatment.
Yeah, and I'll get the same imaging that was done before if possible. So if they had a CT with contrast before, I'll get a CT with contrast. If they had an MRI with contrast before, I'll do the same thing ideally.
Yeah. That way you could compare picture to picture, right?
Yeah. So you're not doing like they had an MRI with contrast before and now you're doing a PET scan. That's not.
Yeah, because you can't compare. Yes, agree completely with you.
And then duration. So this is a little bit more on duration, but it just wanted to highlight 6 to 8 weeks is the recommended duration.
And in this study also they did oral versus IV, and they said it was equal, but again, you have to have a stable patient. Sometimes what I do is start with IV, and if they're doing okay, then eventually after 2 to 3 week transition to a good oral that has good bioavailability. It's every patient is different, so it's kind of patient dependent, but it is a possibility when we're in a good place. But if the patient has endocarditis and bacteremia and discitis, you're stuck doing IV.
No, I agree completely. It's dependent on the patient, and I just try to be very aggressive with spines in general. And then suspected treatment failure. So are the antibiotics not working? Are they getting worse? The first question for me is always, how confident are we that we got the right, not diagnosis with osteo, but how confident are we that we got the organism and we have a susceptibility report? If it was a suspected osteo, but we never had an organism, then I start wondering maybe we should broaden the antibiotics and see if we can give different antibiotics.
Oh, that's a really good point. So like, we were treating somebody for MRSA, spinal infection, but things are getting worse. You might want to add cefepime to cover broadly because it could be a different infection on top. And that has actually happened.
I was going to say it doesn't happen that frequently, but when it does happen, it's bad.
It has happened on rare chances where initially had MSSA bacteremia, was MSSA spinal infection, then ended up having E. coli in there. So it can be tricky. So it's really important to kind of follow these patients very closely to monitor.
Yeah, especially with hardware and things, sometimes the neurosurgeons, they go in several times and it's you could have more than one thing in there.
So that was our end of our presentation, kind of a quick rundown on new guidelines and on vertebral osteomyelitis. And we'll join all of you again next month for the next topic. But any questions on this topic today? I was unclear the impression that linezolid is to be avoided in osteomyelitis.
Oh, this is a good question. So linezolid, when it comes to bacteriostatic versus cytal drugs, that is something that we're all have to memorize in our training and everything. But actually, the person that looked into this was actually Brad Spellberg. Brad Spellberg did a large review of the literature looking at bacteriostatic versus cytal drugs. And it turned out that it was more important which drug it was than if it was classified as static or cytal. So this is a really good thing to bring up. You can use linezolid for osteomyelitis.
But the problem for most of the time for us, it's all the
Mhm.
toxicity, the bone marrow suppression, neurotoxicity, eye issues, and as well as, a lot of patients, if they're on a SSRI, then the
Mhm.
serotonin syndrome. But so whenever I use it, I try to use it less than like 10 days or so.
Mhm.
So for example, if my patient is on vancomycin for MRSA, and I was only used it for 4 weeks, but I need 2 more weeks of oral, then I could
Mhm.
go to linezolid if I
Yeah.
don't have other option because it's a shorter course. So you could use it, but I'm very careful on using just for a short term.
Yeah, I've used it before, but again, I try to make it as short term as possible.
Yes.
Um,
More than 2 weeks is when we get into trouble.
yeah. So if there are any other options, I would prefer a different
Yeah.
option than linezolid. But it does get into, pretty much everywhere in the body
Yeah.
extremely well. Yeah.
Brain, if you want to use it for a short course of pneumonia, it's fine. It's just that course and toxicity.
Yep. But that's a very good question.
Yeah, thank you. Any other questions you all have?
All right. Well, if you have any questions for us, please let us know. Or if you have any topics for us that you'd like to cover like us to cover in the future, please let us know. We like to cover every topic that you'd like.
Yeah, you could let us know, Samaya or Cindy, and we'll be happy to take care of that. Thank you so much,
All right.
everybody.
Thank you,
Have a
everybody.
wonderful day.